work on a population health framework, and we are over the last month have been in interviews looking to hire our 2 grant-funded positions to support this work. So as part of a second interview, when we've hired our ARES, or Applied Research and Evaluation Services team, we usually like to have the individual plan to present some of his or her work, because obviously we're all really passionate around the work that we do research or evaluation in, and so this gives that candidate an opportunity to really share about themselves and their work. And so we're pleased that our candidate, Thilina Bandara, who is currently living and working on his PhD in Saskatchewan, join us for today. And I'm just double checking. I see Mary on the line. And so I will just give a little bit of background about the grant, because again, Thilina, we have quite a diverse team. There's close to 100 staff in the primary healthcare program, and of course this grant is done in collaboration with the Population Public Health and Indigenous group within Alberta Health Services. So Mary has also invited some from that group as well to listen in today. And this grant is looking to combine efforts from our 2 departments, Population, Public, and Indigenous Health, as well as our PHC-ARES group, to create a population health framework. And this will help advance a common understanding of what is meant by population health across agencies and create some indicators across the healthcare continuum. We're also, as part of this grant, looking to test this framework as part of the Zone PCN service and business planning as it advances. So in particular, we're really looking to consider the data that is often available to us currently that helps us understand the demand for services. But it also, when you start to think about that population health framework approach, is looking to address the unmet needs of Albertans, sometimes that are harder to see through our administrative data, and bringing in different ways to tap into those unmet needs. And so it's quite an ambitious project, and we're really pleased that we have had Thilina apply for the position. This is his second interview, and as I said, he is currently finishing up his PhD at the University of Saskatchewan in the area of community and population health services. And so I'll leave our introductions at that. And Mary, do you want to, because I know you tested with Thilina, advise how to share his screen then?
Sure. I've made Thilina a presenter. So Thilina, you should be able to now share your screen, and let's just see if this works.
Okay.
Maybe we can give it a minute to load. It is a pretty large presentation.
Yeah, it takes a bit to upload. Let me just start the process.
Sure. I guess I should have had you start it when I was giving my introduction.
Oh, thank you. Thank you so much for that introduction. It's just uploading right now.
Perfect.
And Thilina, I might ask you to mute your computer, and then what you can do is just talk through your telephone, just so that we don't get any feedback. Yeah.
Sure. Okay. So I'll call in.
Sure.
Thank you for thinking about that. So.
Yeah, because before it sounded pretty good, Mary. So I thought it was okay. As a backup, Mary, do you have his slides? Oh, let's see.
Oops. Just gonna try this again. The call in here.
Oh, it looks like it's loading. Success.
Perfect.
Ah, there it goes, Thilina. Looks good.
Okay, perfect. I'm going to just call in here and Thilina Bandara. Okay, how does this sound? Does that sound okay?
Yes, you got rid of the echo,
Okay.
so perfect.
Yes, I did. Oh, echoes. Okay, so I just muted my computer and ready to go. Okay, so hi everyone. My name is Thilina Bandara. As Judith mentioned, I'm a candidate for the senior consultant position with the department here. So a little bit about myself. I'm a population health researcher. My background is in physiology, and I have a Master of Public Health. And as Judith mentioned, I'm a PhD candidate in community health and epidemiology, where I'm studying public health systems and health inequalities, specifically around childhood immunization coverage in Saskatoon, Calgary, Edmonton, and Regina. I'm also a director and strategic planning chair of Upstream. We're a national think tank dedicated to healthy public policy and the social determinants of health. Come check us out at thinkupstream.net. I'm also a co-founder of the City Centre Food Cooperative. We're a nonprofit cooperative based out of Saskatoon, addressing the need for healthy vegetables and foods in the downtown core of Saskatoon. So we run a small subsidized food market for low-income seniors out of a co-located building in downtown Saskatoon. A little bit more about myself. This is my dog, Birdie. She is a 1-year-old golden doodle, and sometimes people say that she looks like a human dressed up as a dog. So this is Exhibit A of that. So that's all about me. So this is the outline of today's presentation. I'll be talking about some terminology, a little bit of definition about population health, clear up the differences between inequalities and inequities. I'll be using some hypothetical case examples to illustrate my points, discuss 3 levels of how to increase population health in a health system, and also have a brief outline of how to do population health at a large scale. Okay, so population health refers to the health of groups of people as measured by health status, which in itself may include many outcomes that are influenced by social, economic, and physical environments, personal health practices, individual capacities and coping skills, human biology, early childhood development, and health services. As an approach, population health focuses on the interaction between these determinants, differences in subpopulations, and how this knowledge can be translated into policies and actions to improve health. As the federal government defines it, health in the context of population health means the capacity of people to adapt to, respond to, or control life's challenges and changes. In this way, health is more of a potential human beings can reach in an ideal environment. It is when those environments are less than ideal do people not reach their full capacity, and populations therefore suffer. So just to reiterate, population health as a perspective explicitly rejects the notion that any one individual is an isolated being and that their health is solely an individually created phenomenon. It's more concerned of how healthy groups of people are. This is best measured by comparing groups and understanding differences in the determinants that may account for those health disparities. getting some feedback from someone's mic. Okay, it disappeared. For example, we may be interested in how one group living in one environment compares to another group living in a different environment. In this case, we consider neighborhoods, for example, different environments. And as we know, neighborhoods are actually different physical and social environments. We might also compare a group of individuals who are high income and compare them to a group that's low income. Again, we know that these two groups represent two different environments, socially, economically, and physically. The key is that we're comparing groups or subgroups based on the determinants of health. One key thing we have to know before truly understanding population health is what these differences mean, what we call the differences. Differences in health outcome between groups are always considered health inequalities. So inequality meaning one is bigger than the other. A health inequity describes something slightly different. A health inequity is an inequality that is also avoidable, unnecessary, unfair, and unjust. Let's go to a visualization to explain what I mean. Let's say we're interested in deaths due to cervical cancer in a population. What happens when you compare the rate of death to cervical cancer between men and women? Indeed, only women can get cervical cancer biologically. It's possible that men can also get HPV cancer, but if we're looking just at cancer of the cervix, there's a biological difference in the incidence. This is a health inequality. Women get more cervical cancer than men. The same is true if you flip it around and track testicular cancer, for example, between males and females. What if, however, we compared low-income women to high-income women? Although it has been getting better, we know that rates are indeed higher for low-income women when compared to high-income women. On the left, this is unfortunately the most recent data I could find on the topic in Canada, and on the right is the US data. You can see in both cases, this inequity is both apparent, and endemic, and persistent over time. So just to explain the charts a little bit more, the one on the left is the Canadian data, like I said, at 4 different time points. And the Qs represent sort of quintiles, so 20% of the population. So Q1 represents the least deprived, so the highest income population, and Q5 represents the lowest income people in that population. And you can see, even though overall rates are decreasing and the inequities are also decreasing, it's still persistent and sort of endemic in a Canadian context. The chart on the right shows the same thing, but in the U.S. context and over more years, and you see that the 5th quintile, so the dark gray one, so that's the high income people, consistently have lower rates of death due to cervical cancer than those in the 1st quintile, or the lowest SES people. So this is an inequity. The difference being that there's no unavoidable reason that income should dictate the inequality in rates of deaths due to cervical cancer. It's an unjust distribution of disease. Again, this is based on comparing subgroups based on the determinants of health, but through a value-driven lens of fairness and justice. Unfortunately, this kind of population health analysis is showing us that one socioeconomic position is associated with many health outcomes, in that for many conditions, the lower your income, for example, the worse off you are likely to be. This slide shows some Alberta data portraying inequities in all-cause mortality, so that's on the top left, The bottom left is infant mortality, and the one on the right is lung cancer incidence. Notice how it is not only the richest and the poorest showing the large differences. There's also a parallel gradient in health outcomes and social outcomes. The lowest income group being worse off than the second lowest, the second being worse off than the third, and so on. So just to explain these charts a little bit, the blue means both sexes, green is males, and yellow is females, and each chunk represents a different quintile. So the first quintile represents the lowest income folks, and then Q2, Q3, Q4, Q5 to the highest income. And you see this gradient, not only so it's a stepwise gradient in all three of these cases, and this is Alberta data. And this data is actually very publicly available if you go to the Public Health Agency's info-based data set. You can build these type of data for all different provinces and nationally across many indicators. It's a really great resource to use. Understanding health at this scale allows health policy makers and practitioners to see that current efforts to make the population healthy at large are not reaching people equally between subgroups. Population health is therefore a perspective anybody can take. It's also a theory or a working model that animates how the external world affects populations, ultimately giving us insight into the questions, why are some populations sicker than others? It's the opinion of many of the primary healthcare professions that action on the social determinants of health is paramount if we are to make gains in a population health as a whole. CMA reports that addressing inequities caused by the social determinants of health makes economic as well as being a compassionate approach. Indeed, the CMA estimates that 50% of what makes Canadians sick are associated with the social determinants of health. Mirroring the sentiment is White, describing health as being made at home, the community, and the workplace. Key to population health is understanding that individuals are subjected by ever-expanding spheres of influence, not isolated, but connected to each other in the environments that everybody shares. I want to run through some hypothetical cases to illustrate how population health perspective informs the work of any one primary healthcare professional. First, let's describe a patently non-population health perspective look at some patients with kidney disease. Let's say patient 1 has uncontrolled diabetes, which is poorly managed. Patient 2 is obese, has uncontrolled high blood pressure, which is poorly managed. And patient 3 is a heavy cocaine user, indicating glomerular lesions and kidney disease. Through this individualistic lens, one's theory of disease may be that the causes of diseases are indeed biological in nature and the results of individual mismanagement of disease states. The data you may use to make this decision could be based biologically in nature, so the result of samples and clinical tests, a clinical history of the patient informed by medical science of how these diseases work, the pathology of kidney disease. Your model may be the following: unhealthy individual behaviors leading to disease. Let's take the same case and apply a population health perspective. First, one understands that a patient are indeed parts of communities with their own distinct social, economic, and physical environments, with economic and social capital that allow citizens to live healthy lives. Upon closer inspection, we may learn that our three patients may have been subjected to some maladaptive environments, specifically in our case, poverty, unemployment, and childhood trauma. we now have a new theory of disease, adding causes of causes, social, economic, and environmental factors, which we can investigate further using sound population health research. Including population health data will inform what those determinants may be and where the solutions may lie, adding another element to our model of disease, social, economic, and the environmental context patients work, grow, and play in. Specifically looking at what health systems can do, Newdorf outlines 3 levels of action in health systems to improve population health. Number 1, health systems can directly deliver population-based disease prevention and health promotion activities. This is, as anyone who works in public health knows, is exactly what public health does with services like immunizations, antenatal care, health education, and screening, utilizing a community-oriented practice model. Public health practitioners are therefore the experts in the health system on local needs and can communicate that to other primary care providers. This bridge is vital to integrating the community's perspective to primary care. But it's not only public health that can do this. An example is the Norwest Community Health Centres in Northern Ontario. They recognize that the current model of healthcare does not work for their sparse, disparately placed populations. They leapfrogged the idea of building one healthcare institution and developed a co-location model and a mobile model of primary healthcare that is tailored to their senior population. They provide interdisciplinary care by partnering with organizations in a number of small communities that they travel to deliver care that considers social, economic, and physical barriers to health. Again, they cover a huge area, utilize, they're based out of Thunder Bay. This is their co-location space. They utilize a mobile team of community health workers, a foot care nurse, and a nurse practitioner, and set up in any available space they can to provide healthcare services to these remote seniors. So this is a great example of a population health-based healthcare model. To quote one of the leads of this model, they start with the needs of the population first, then looked for partnerships to fulfill those needs and to meet patients where they were at. The second level for action for improving population health in healthcare organizations is by integrating population health into the health system at large. This can be done by A, investing in population analytics and data utilization in management, so feeding in population health research data in real time to make decisions. Conducting equity audits, so reviewing services and structures to test the availability, accessibility, and acceptability and outcomes of those services to vulnerable patients in the population that you are serving. Conducting health equity impact assessments on healthcare policy decisions, which I'll get into in a little bit here. And having population health representation in leadership at the system level. So having, for example, medical health officers of health at the table, at the executive table, in the high-level policy-making decisions of a healthcare system, to bring those population health perspectives to high-level decision-making in a system. To go back to the health equity impact assessments, this is an example of one that I've sort of played around with at my time at the Public Health Agency of Canada. This is from the Ontario Ministry of Health and Long-Term Care. So it's a example of a tool It's very easy to use and has a thorough guide available with it online. And this tool can be applied to almost every program, service, and policy a health system can implement, and can detect holes that would otherwise go missing in your program and policy making. On the left, you can see you start with the populations that often experience unintended health impacts due to current policies and programs. You then ask what determinants they may be subjected to. What are the potential impacts on these populations? How to mitigate those impacts, how to measure those impacts, and what the recommendations are in the end. The third level is at the advocacy and intersectoral partnership level, the large-scale actions that go beyond health. Healthcare professionals can advocate for policy change at any level, federal, provincial, and municipal levels, and leverage their influence on the many boards, councils, and committees that drive policy change in any given jurisdiction. Those in the health system can also collaborate across silos in things like early childhood partnerships, poverty reduction campaigns, and advocacy around food security, for example. In Alberta, you can see that of the 1,495 active coalition members in the early childhood coalitions, 13% of them are from health. There's also health representation on the End Poverty campaign in Edmonton. And the same is true for similar campaigns in Saskatoon as well. So how do you do population health at the sort of broadest strokes? It's a question where the answer is not always clear. Indeed, population health intervention research is in a nascent phase of figuring out what works and what doesn't. What we do see clearly in the world is that more equal societies with stronger social safety nets, with good family and environmental policies, generally do better than those that do not. To get to those solutions, individuals and organizations need to maintain a broad perspective of health, invest upstream to target the causes of causes, provide evidence for the way things are and for the way things ought to be. So, for example, the way things are, regular reporting on health inequities, and furthering the population health intervention research agenda to see what policies and programs work to reduce gaps in health outcomes. Consider the social determinants of health as complex. Collaborate with people across sectors to tackle that complexity. Include citizens into program and policy design. And to include population health outcomes into our accountability frameworks, to make sure to hold our systems accountable to population health outcomes through the use of robust evaluation. So today I've only scratched the surface of population health. It's a vast topic, but I hope I've imparted on you today what that population health is, broad in scope, based on values of fairness, justice, equity, mostly involves those outside of health to address those larger social determinants of health. But those in the health systems must do their part, leveraging their leadership, evidence that they generate, and value-driven practice to improve the health of populations. So, is there any questions? And thank you for your time.
Great. Thanks so much, Thilina. You certainly have given us a lot to think about. And so I will open it up to whether people want to type questions in the chat box, or if you want to just take yourself off mute and ask a question. So I guess I'll start, Thilina, just to give people some minutes to think. I would say within Alberta, we're still in the very early developmental phase to really promote this sort of work. I'm curious, in your opinion, because you've worked in some national positions, who within Canada do you think is kind of the lead in some of this work right now?
Sure. So, luckily enough, my supervisor, I think, is a champion on this topic, Dr. Neudorf. He is Chief Medical Health Officer here and has worked in public health. A lot of what he's written about is the experience that's happened in Saskatoon and the major gaps that have been closed here. That sort of happened due to sort of a shock moment in 2006, where a big report was done by him and his group, showing explosive health inequalities between the river in Saskatoon here. So the west side versus the east side, and the differences in incidence of suicide, mental health, all these different indicators. And so that report sort of jolted people into action. They went out to the media, and he's had a lot of work, a lot of experience leveraging what he's done at the board level in the health region. So he's a good person to go to. There's actually a lot of great information through the National Collaborating Center of Public Health. There's 5 of them. It's a long name, National Collaborating Centers of Public Health. There's one specifically about the determinants of health. They're based out of Nova Scotia. They have a lot of great literature they've been documenting for many years now, all of the gains that different jurisdictions have been making on this sort of quest to reduce health inequities. Examples from Ontario, examples from Manitoba, Saskatchewan, all over the country. So I think working with the National Collaborating Centers, and they're sort of built to do this kind of work to help people on their sort of journey to be more of a population health organization. That's a really great resource as well. There's lots of people. If you find anybody who's done this work, in my experience, they're very willing to help, and they're very excited to be a part of that kind of learning.
Judith, this is Shanaz. I just wanted to kind of make a quick comment about some of the work that has been happening historically in Alberta within different zones, either focusing on the health of Indigenous people, and the current work that Indigenous SCN is doing, more focusing on these social determinants of health in terms of improving access, in terms of improving the competency of providers to know more and to be responsive around these social determinants of health, and then other groups focusing on, for example, social determinants of health impacting people like homeless people or other, vulnerable groups. So there are a lot of pockets of excellence existing here in Alberta, and a lot of research has been done around this, but it is just a matter of coordinating and aligning all of these pieces of work together to have a provincial approach to it. But I guess knowing from my own, past experience, I know that a lot of work has been done in and is happening around social determinants of health.
Yeah, that's a great point. I've seen a lot of great work come out of the Healthy Public Policy Unit at AHS. Even in the like I showed the Health Equity Impact Assessment, there's a whole review that was published in 2017 about a lot of those, and that's they're really eager. I had a chat with somebody there as part of my dissertation research, and a lot of the equity stuff that's coming out of there is very, very exciting, and it'd be great to get them involved.
Are there other questions for Thilina?
Hi, Judith. I have this is Richard. I have a question.
Sure.
So first off, thanks. It was a great presentation. I just one of the most important stakeholders in healthcare and AHS specifically is physicians, right? And physicians are and clinicians typically want to improve the care of their patients. Now, improving the care of the patients and finding new information to prove that is obviously of value, and they're also typically the first point of contact for people in the healthcare system, even if they're underserved.
Yeah.
Now, in a population health, if you look at population health metrics, you can't actually apply, a population health metric to the care of a patient. It just, that happens to be in that group, it doesn't work out. So I'm just wondering how you plan to make a population health framework, which is different than clinical health, useful for physicians who will definitely be involved in this process in order for it to, just be accepted. So I just wonder if you could comment on that.
No, that's a great point. And specifically on this framework building issue, there's a report that comes out of Canadian CFHI, Canadian Foundation for Healthcare Improvement. They did a big review about this type of work, so building population health frameworks and so building in accountabilities for all primary healthcare people. They mentioned that nurses are the sort of biggest players in bringing these frameworks together, and that in a lot of ways doctors are disincentivized to do this kind of work. They mentioned specifically a big part of it is there's not really an incentive structure built in for prevention work for physicians, and some physicians in the report they mentioned that there's some reticence around group decision making, getting away from the sort of lone wolf mentality, and so to remedy that, I wish I had the answer, but I don't know if anyone really does. I think that's using the intelligence that was out of that report and sort of coming at it in a way that's Alberta specific is going to be very important to me. Engaging physicians early, finding physician champions that are interested in this population health model, and working together to come to at least a shared understanding of how population health should be viewed, sort of shared language across disciplines. And I'd be excited to tackle that issue. It's definitely an issue, and it takes a lot of engagement and collaboration. So thank you for bringing that up.
Okay, thanks. Yeah.
Hi, Thilina. Can I ask a question there?
Sure. Go ahead.
So my name's Robin, and I'm a scientist within the Applied Research and Evaluation Services. And I just had a question regarding the tool that you showed us, the HEIA tool, just because I've never seen it before. So I was wondering if this tool has been used in projects or policy that have been shown to improve population health care or potential some inequities, and if you have an example of that.
That's a good question. I haven't seen any real outcome data to this. A lot of the outcomes to this aren't often published, but I can definitely look into that. My experience with the tool is that I took this framework of this template and developed a list of questions, making it more of a lens. So developing a list of questions to go. I was working at Public Health Agency of Canada at the time, and what I did was transform this template into a lens that the National Advisory Committee on Immunization can use, so they can run their immunization guidelines through this tool to understand if they're missing specific recommendations in their guidelines that would be missed otherwise. So I've used it in a sort of different way. As for actual outcomes based off the template, this kind of work is implemented in a lot of places, so I imagine it does work, but I can't really not up top of my head, can't really think of any sort of pre-post understanding of how this template has reduced inequities. More of a, I see it more of a mental exercise for anyone who's developing programs and policies.
I can jump in really quickly and just mention how this came about. So Bar High in the Bay Area in San Francisco started with this health equity impact assessment. And when I was there, I was part of this group that uses this type of an assessment for policies. It has been used extensively for looking at the impact of policies that are that they're thinking of adopting or implementing, right? So within the Bay Area, we used it a lot for community and neighborhood improvement. So, for example, transportation is a big area there in terms of getting people access into clinics, into hospitals, and just from the neighborhoods, right? So the transportation policies were definitely impacted by using this type of an assessment. The other neighborhood things would be like food, like locations of like grocery stores, for example, zoning. So we used it for that as well. And that was tied to farmers markets that are offered within hospitals and clinics as well. So it is used actually extensively in regions. I don't know about the Canadian context. I only know that this is used by Ontario, but I don't know within Canada, in the Canadian context, whether or not this has actually been used for policy analysis. I heard that it was, but I'm not sure for, yeah.
Yeah.
Okay, thanks so much. That was really helpful.
Thank you for the question.
So we have a few more minutes. So are there any other questions before we wrap up today's presentation?
Hi there, it's Dan. And I'm on the primary healthcare team as well. I have a question with respect to, I noticed in one of your slides it talked about childhood trauma, and I know there's a lot of airtime being discussed about ACEs, and so that's been definitely hitting our radar lately. But I'm wondering, is there anything that you have found on loneliness and social isolation? Has that been hitting the radar too? Because they're saying that that's definitely attributing to greater mortality and as an influencing factor. So I'm just curious on what you found.
Yeah, so the loneliness aspect from the research that I've seen, really there's a lot of chatter around older adults. So older adults who are lonelier suffer a great deal more of not only sort of the physical results of aging, so falling, right? For example, an older adult that's fallen and is alone will have a worse time recovering, but also the mental health aspects. So that's the social. That's where the social capital and the social cohesion of communities comes in. I think that's very important. That's been on some people's radars as we're starting to talk about senior strategy. But yeah, I haven't heard anything about the children's part. If loneliness is intersected with the ACEs specifically, but yes, that's a huge deal, and that's definitely sort of perfectly outlines the broadness and the.
Right. Would you say like the top three though still are poverty, food insecurity, unemployment, childhood trauma as being, or I guess that was the other part of my question, if there was some that are more important than others at this point?
I'm not sure if we lost Thilina because he was showing up as two different squares coming into the call. Unfortunately, I see one dropped off. So I think it's a really thought-provoking question, Dan.
Maybe I'll kick it back to you, Judith.
There you go. Oh, Thilina, I'm sorry. I thought you might have dropped off. Do you want to answer Dan's question?
Sorry, I might have missed it. I think I dropped off.
Yeah, I think you dropped off for a second. Yep.
Yeah. No, I guess the supplemental question was poverty and food insecurity are listed on your slide, unemployment and childhood trauma. Were those three significant ones especially, or those were just three that were noted just for the slide? I just wanted to get a sense of severity with those ones over others.
Sure, yeah. I chose those three based off of the sort of hypothetical profiles of the patients.
Okay.
So the sort of the patient one having the diabetic issue, the food security.
Gotcha.
Yeah, it sort of lines up nicely. The childhood trauma with drug abuse. We know that childhood trauma, sort of interferes with long-term planning and those sort of psychological and cognitive effects of childhood trauma can affect addiction behavior. So those are the ones. Yeah, those are the reasons why I chose those.
Yeah. Okay. No, thanks.
Yeah.
Great. Well, I think we're at our time now. I think, so we've had close to 50 individuals call in today, Thilina, to hear your presentation. So obviously there's a lot of interest and, I would almost say excitement about advancing this work and using this grant opportunity to have conversations like we've had today with a variety of audiences. And so, several of us will move to an interview with Thilina starting at 3 o'clock. And so I just want to give them a little bit of time to take a break. And again, thank you so much for those who spent a bit of their afternoon with us this afternoon. So we'll connect on our other line at 3 o'clock, Thilina.
Okay, so should I drop off this one? And
you could take a little bit of a break and then, we'll get on at 3.
Thank you.